Hello everyone and welcome to the TRSP Webinar Series for 2024. So it's my real pleasure to be back this year with another series of webinars hosted by the Tertiary Referral Service for Psychosis. My name's Julia Lappin. I'm a psychiatrist and a researcher with expertise in improving outcomes for people living with psychotic illness. I'd like to begin with an acknowledgement of country and of lived experience. I acknowledge the strength and resilience of Aboriginal and Torres Strait Islanders people, who are the traditional custodians of the diverse countries from which we're joining this meeting. I'm privileged to be calling from the land of the Gadigal people of the Eora Nation, and I pay my respects to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people joining today. I also acknowledge people with lived experience of mental ill health and recovery, and the experience of people who have been carers, families or supporters. So welcome to our Mindgardens TRSP Seminar Series. The Tertiary Referral Service for Psychosis is a New South Wales Health funded statewide service hosted by South East Sydney Local Health District. And we're very grateful both to New South Wales Health and to CESLED and to the Mindgardens Neuroscience Network for their ongoing support of TRSP. At TRSP, we aim to improve the lives of people living with complex psychosis through the delivery of our clinical service, which welcomes referrals from across the state of anyone living with psychosis and cared for in public mental health services. We also run education and training programs aimed at developing a community of practice for capacity building in complex psychosis care. And this webinar series is an example of that capacity building. This series will run throughout 2024, monthly after our successful 2023 series. So please look out for emails from TRSP events, which will detail future webinars, all tailored for clinicians. And before we start and introduce our speaker today, I'll just go through a little bit of housekeeping. You can write your questions in the Q&A, but you can't speak or be seen. There'll be opportunity to ask questions of Nick in the last 10-15 minutes today, and we'll finish promptly at 1 o'clock. There will also be a simple anonymous poll towards the end of the webinar. Please complete it so that we know how useful and valuable you found it or otherwise. We also appreciate your feedback by email. And I want to let you know that this event is recorded and that we'll distribute a link to the event video with 2 weeks to those who've provided an email address. You can opt out of our communications at any time with a return email with unsubscribe in the subject line. So finally, I'd like to introduce our speaker today, Dr. Nick Burns. Nick is a forensic psychiatrist with 13 years experience in forensic rehabilitation, working initially in secure settings and more recently in community-based forensic rehabilitation. He's a member of the New South Wales Mental Health Review Tribunal's Forensic Division and has particular interest in working with people with severe and persistent mental illness and complex care needs. Nick is chair of the Royal Australian New Zealand College of Psychiatrists section for Social, Cultural and Rehabilitation Psychiatry and was recently appointed clinical lead in rehab psychiatry for the New South Wales Ministry of Health, where he's working to develop clinical leadership in rehabilitation psychiatry. He's also interested in the social determinants of mental health and in particular the relationship between homelessness and mental illness. He consults to several homeless men's shelters in inner Sydney. So it's my great pleasure to welcome Nick, who's talking to us today about a topic that was voted the theme of most interest for a future TRSP webinar. Nick's going to talk to us today about understanding and managing the risk of violence in clinical settings. Thanks, Nick.
Thanks, Julia. Now you guys can hear me clearly and the slides are visible. Anyway, I'll presume that you can hear me and you can see everything till notified otherwise. Thank you for that introduction and thank you for the opportunity to talk today. So I am really a clinician. I'm not a researcher. I'm not an academic. So I'm going to talk about this topic from a clinician's perspective, and hopefully people will find that helpful. It's going to be very broad brushstrokes just because of the constraints of time. But I'm happy for people to ask questions both in and outside the session. And there's an email address there which you can contact me on. So I'm more than happy to chat into the future if there are questions that people have or there are resources that people want to get their hands on. Okay. So we're going to try and wrap it up by 1:45, so we've got time for questions. Why is this topic important? Really, stigma is something that psychiatric patients on the whole face, and certainly in the community's minds, there is still concern, I think, about violence that is associated with mental illness. It's a popular perception that comes through in popular culture and also when crises hit the media. So I think it is an important thing for us to discuss. When these things happen, there's often an erosion in the confidence of mental health services to deal with it. And when violence occurs, certainly in clinical settings, there can be long-term consequences for both our service users and staff. And especially in those contexts when there's litigation, it generates a lot of anxiety in staff. So whether we like it or not, the public expects that we will be involved in the management of violence in people with mental illness. So it's probably important that we embrace that and take that issue earnestly. So what we'll explore today, this is a rough outline of the talk. First, I'm going to examine the relationship between psychotic illness and violence. More broadly, it's about mental illness and violence, but I've really chosen to focus particularly on psychotic illness, certainly in the context of the work of TRSP and the audience today. Then I'll talk about methods for assessing the risk of violence. Then I'll talk about the key principles of managing the risk of violence, and this will be from my experience in forensic psychiatry. I'll very briefly skirt over the relevant legislation that pertains to this. And then I'd like to end on a good note, which is looking at a particular population of mentally disordered offenders and how they fare in forensic contexts. Okay, so let's kick off with exploring the relationship between mental illness and violent offending. Is there a relationship? And certainly before the 1980s, the view was that they occur independently, so crime and mental illness occur independently, and there was some suggestion that schizophrenia may be protective, that it may be inversely related to the risk of violent offending. So that view's changed over the last 4 decades in the context of examination of various areas of the literature. And in summary, what it's confirmed is that there is an increase in the risk of crime and violence amongst those with mental illness. Now, we'll really interrogate that a bit further. But there are the 3 main bodies of evidence that we've examined. One is looking for the prevalence of mental illness in custodial prison populations. 2 is looking at the prevalence of crime and violent offending in mentally disordered populations. And the 3rd area is looking at unselected population-based studies and what they tell us. So the first of those, looking at the prevalence of violence amongst those with psychosis, there's a very good study, Australian study, looking at 2,861 individuals with schizophrenia and matched controls, looking at their criminal records, and their findings were that violent offending occurred in 8.2% of the individuals with schizophrenia compared to their matched controls. So showing that there's a far greater incidence of violent offending in people with schizophrenia in their population. And they really noted the important contribution of comorbid substance use, which is a major confounder and mediator that we'll talk about a little later, but one to definitely keep in mind. Then looking at the prevalence of psychosis in violent offending populations. So this is a study by Feazell and Dinesh, which is a systematic review looking at a large number of prisoners. And it showed far greater rates than the normal population average of psychotic illness. So 3.6% of the men and 3.9% of the women had psychotic illnesses. And when we look at population rates of schizophrenia, it's between 1 and 2%. Now, interestingly, it showed that in low and middle income settings, there were even higher rates. And this tells us about another confounder or mediator, which is about someone's environmental circumstances. So the big population studies that have been looked at include the the epidemiological catchment area or ECA studies, the Dunedin birth cohort studies, and also the Danish register studies, amongst others, which are big cross-sectional population studies. And what they've shown is that there is, so that slide's a bit busy, unfortunately, but condensing it, what the pooled results show is that there is an increased odds ratio for those with psychosis and violent offending, so that the two are correlated. Okay, so looking at that in summary, this a view by Whiting and al. Says that there are relative risks typically increased for all violent outcomes in most diagnosed psychiatric disorders, so that's broader than just psychosis, compared to people without psychiatric illnesses, with increased odds in the range of 2 to 4 after adjustment for familial and other sources of confounding. Absolute rates of violent crime over 5 to 10 years are typically below 5% in people with mental illness, which increases to 6 to 10% in people with personality disorders and schizophrenia spectrum disorders, and to more than 10% in people with substance misuse. Okay, so in summary, through those sources of data, we can see that there is some association between mental illness and violent offending, and between psychosis and violent offending in particular. Okay, so what is the nature of that association, and is there a causal link? So the three things that we'll look at are the role of confounders. Second, we'll examine whether there's a temporal relationship. So that means, is there a temporal relationship between developing schizophrenia and violent offending? And is there a relationship that is specific to psychosis? Okay, so this slide looks at the kind of mechanisms, if you will, that link mental illness to, or in a theoretical sense, link mental illness to violent offending. And in between the mental illness or psychosis and violent offending, we have either confounders. So that's potentially factors that coexist that independently predispose to the commission of violent crime, or there are mediators. So something that occurs as a result of the mental illness that then leads to the risk of violent offending. So there are some accepted confounders. We know that in younger people, there's a greater risk of violence, also social and economic disadvantage, and also gender. So men are typically more violent than women. There are some factors which are potential confounders, but also possibly mediators. And they include the factors listed there, including substance use, cognitive impairment, poor social functioning in relationships, and impairments in empathy. And so they could either be independent risk factors, or they could be things that result from a mental illness and then predisposed to violent offending. And then there are things that are likely mediators. So they include active psychotic symptoms and the associated changes in affect. So just to reiterate, men commit more violent offences than women in general. And usually it's young men, and it's often in the context of alcohol. And it's often done in group situations where there needs to be a kind of show of bravado, if you like. So it's really important to remember that factor, and that's a significant confounder. But we do know that in clinical populations, there is a narrowing of that margin of difference between men and women. And you can see there that the rates of violence in the second two columns, inpatients and outpatients, which is a clinical population, that the rates are much more even. Okay, so looking at psychosis in particular and what it might be about psychosis that leads to this risk of violent offending. And there are particular psychotic symptoms that might contribute. So TCO there with a question mark refers to threat control override symptoms. And they refer to symptoms where somebody might feel that violence is necessary in the context of a delusional belief, even if it overrides their own moral judgment about that. So, for example, someone might believe that it is necessary to kill their mother or their father, even though they're opposed to that kind of activity because the threat is too significant based on a delusional belief. Also, delusions of infidelity and jealousy. There is much talk about command hallucinations where there are specific instructions to commit violence. And I must say, in my 14 years as a forensic psychiatrist, I haven't actually seen that occur very often. Psychosis might lead to distressing changes in affect, so fear and anger, which might precipitate violence. Okay, so what are the potential causal mechanisms? And we have various hypotheses, really 3 hypotheses that you can see here. One is that psychosis might directly lead to violence through some of those mediators of the illness that we talked about. The second is that there might be a common vulnerability, so genetic and environmental early life vulnerability that can lead to both psychosis and violence. And the third is that psychotic illness might feed into and enhance early life vulnerability to lead to a risk of violence. So I guess really what's hard to determine in a causal relationship, it's important to be able to prove that in a temporal sense, one event leads to another chronologically. And so what we're really looking for is a body of evidence that helps us to interrogate that, whether the violence might precede the onset of mental illness and in particular psychosis, or whether the violence postdates the onset of the mental illness. So some studies that help us examine that are the Danish register studies. Now, the Danes are very good at population-based evidence, and they've linked 3 very comprehensive databases, which really essentially look at these factors independently over an extended period of time, so that the correlations of the temporal relationship can be examined and correlations can be examined. I hope that makes sense. But what it's essentially shown is that there are significant associations between violent offending and psychosis, both before and after the onset of disorder, which really hints that there might be common causal mechanisms for both, or that there might be some kind of bidirectional relationship between the two. It shows that there is a strengthening of the relationship after the onset of the illness. So the post-onset offending is more closely related to diagnosis, and that is particularly so for women. And it shows that the differences between men and women in terms of their relative risk, it's pretty even, except for in that post-onset phase where there is a stronger relationship between violent offending and illness for women. So those studies are quite helpful. I just wanted to mention these studies by Matthew Large and Olaf Nielsen, because I think they're really helpful, particularly in a forensic context. And what their studies showed were that for violent offending, most of the offending occurs in the first episode of psychosis, and the vast majority of it occurs before people are engaged in treatment. And I think that that's really important, because certainly in a forensic context, we have people being managed in custodial settings or contained secure settings for really extended periods of time, where what we can tell from these studies, or what it suggests, is that it's really that very early phase of the onset of illness when people are most at risk of violent offending. Okay, what about the role of diagnosis? So is the risk psychosis specific? Well, what we know is that there is an association between mental disorder and offending, and it is not specific to psychosis. And in fact, the association between psychosis and violent offending is not particularly strong. And that when there's been an adjustment for effect sizes, the effect sizes for men were in the order of 2 to 3, which is not huge. So really this lack of diagnostic specificity points to mechanisms and risk factors that are common to a range of diagnoses, rather than specifically for psychotic illness. This slide is really just to tell you that for that increased odds ratio in psychosis in particular, that the risk is greater for women, and that's specifically in the post-onset of illness phase. I wanted to talk briefly about psychiatric hospitals as a kind of unique context, and I know that a large percentage of you don't work in inpatient settings, but they are very particular settings, and whilst we won't have time to really explore it in detail here, it's settings often where a large number of people are operating under a great deal of stress, often where there are restrictions on their movement and their liberties, who are in very vulnerable positions, and that often leads to aggression in that context. And there's been some studies that indicate that the main purpose for violence in that context seems to be around reducing of tension. So it has a tension reducing quality to it. I just thought I'd raise that because there might be some thoughts that people are doing, engaging in violent acts in a kind of instrumental way to observe the impact on other people or for kind of antisocial reasons, but that's not necessarily the case. Now, this isn't a talk about inpatient settings in particular, but I think it's important to sort of understand the motives in that context. And finally, in this section, I just wanted to really make the point that people with mental illness and in particular psychotic illnesses are actually at greater risk of victimization, so being victims of violence themselves, which means that they are a very vulnerable group of people. And that's come through both in the SHIP studies in Australia, but also the Danish population studies that show that there is an increase in risk for men and women of being victims of violent offending. Okay, so what are the overall conclusions? That there is a statistical association between mental illness and violent crime, that the assessment of what is a confounder and what is a mediator is complex, but we do know that two key other factors to consider are substance use and also personality pathology. That the association is present both before and after the onset of mental illness. That the association is present across the diagnostic spectrum, and that there is also an association between mental illness and being a victim of violence. So the implications of this, and this is a news story from 2013, is that, and this is the opinion of Paul Mullen, who is the forensic psychiatrist on this slide, is that it is our business. It's the business of mental health services to try and reduce the risk of our service users hurting other people. Okay. So I'll try and speed up a bit, and apologies for this because it is a big topic to try and cover. But so what does that mean? Well, we really need to try and have a structure for both assessing and managing the risk of violence. And this is obviously particularly important in forensic psychiatry, where people have already committed serious offences. And it's probably going to crop up in clinical circumstances. You're going to think of it mostly when service users have displayed violent behaviour. But when would we do this? Well, really we can do it at any stage of someone's engagement with the service. Typically, in a forensic setting where I worked, we would engage in assessment, a risk assessment, every 10 weeks, which would be the time of someone's case review, or at some significant crisis, or at the point of discharge as we're preparing to move someone to a lower level of security. Now, I'm not suggesting that all of these structured assessment processes should be employed by all parts of clinical services. And if you are considering using them, then it's certainly worth getting in contact with the experts in your area who will be the forensic services. But it is good to keep in mind. So what are we trying to do in assessment? We're trying to look at the risk, which is the probability of a particular outcome, which is a violent event in this instance. A risk factor is a factor that's associated with the risk of that outcome occurring. And risk assessment really tries to evaluate that risk. And what we try to do is really identify particular risk factors that then become areas for management. And important to know that those risk factors are not just clinical. We're really looking at a range of socio-demographic variables that we know are associated with high risk of violence. Just a point to make is that we're really not in the game of risk prediction, because we're really very poor at predicting a risk of future violence. So what we're trying to do really is to assess in a structured way, looking at particular risk factors, and so we can try and devise a management program that will address those risk factors. So what is a risk factor? Well, it's something that's associated with the risk of a particular outcome. And we talk about static and dynamic risk factors. And static are those that are historical. They've occurred in someone's past. And in that sense, they're not particularly modifiable in terms of management. But we do know from empirical investigation that they are associated with an increased risk of violence. And we'll look at those in a minute. Dynamic risk factors are risk factors that are changeable, that are occurring in the present or in the near future, and are things that we can target in our treatment plan to try and modify the risk of violence. Just to reiterate here that we're really looking at trying to assess for the risk of violence, and not a lot of these other outcomes that are also things that we look for in our clinical practice. But this is really about the risk of violence. So this is just a definition for what violence is: actual, attempted or threatened infliction of bodily harm, which can be physical or psychological, to another person, that is deliberate and non-consensual. And what are the dimensions of that risk? So we're looking at not only the nature of it, what do we think is the likely outcome, but its likelihood of occurrence, how frequently violence might occur, the seriousness of the consequence, what would be the context for that to happen? Would it happen at a pub? Would it happen in the domestic situation? And also what the imminence of that violence is. Okay, so we're really trying to understand these things when we're formulating our risk of violence. So what is the drive? What is the desire? Is it driven by psychotic symptoms or non-psychotic factors? And what are the internal inhibitors and external inhibitors that need to be overcome by that person before they might engage in that act of violence that is in their minds? Okay, so there are lots of ways of doing this, but there are three broad categories. The first is what we call actuarial assessment, and that's really looking at the evidence that interrogates what clinical and demographic factors we know are related to violence, and putting them in some kind of structured questionnaire form, and then using those to guide us. And as you can see, there would be some benefits in that because it's empirically based, but it also does not take into account someone's clinical professional acumen, and also the particular circumstances for the individual, what we call idiographic factors, or an idiographic understanding of that particular person. So at the other end of the spectrum, we have assessments that are entirely unstructured, and we call those professional judgment. And there are lots of benefits for that because it does really rely on expertise and takes into account the individual circumstances, but it is highly unstructured and it will vary from person to person, and there is no kind of empirical basis for it. So we use a third type of risk assessment called a structured professional judgment, which occurs somewhere in the middle along that spectrum, taking into account both an empirical body of evidence, but also understanding that clinicians have particular skills in their assessment of people and in knowing the person in front of them. So taking into account those idiographic factors. Now, I don't have a lot of time, but in brief, in my work in forensic psychiatry, we use a lot of risk assessment tools, some of which are strengths-based actually, but the three that we used commonly were the DASA, which you may have heard of, and then for the medium to long-term risk, the HCR and an anamnestic assessment. And I just want to tell you that these are structured tools that we find useful, and you too might find them useful. If you're seeking guidance on how to use them, I'm only going to give you the very broad brushstrokes here. So please feel free to contact me afterwards. But there are plenty of risk assessment tools available. So I'll talk briefly about, well, two main ones. One is the HCR, and this was developed in Canada. And it, as I said, it really tried to provide, to marry empirical evidence, what we know about demographic and clinical factors and association with violence, but also the individual circumstances. And it can be used in a range of settings, but it does need training to be able to use it reliably. And we're really not trying to predict risk of violence, but what we're trying to do is identify risk factors that can then be used in a management plan to try and reduce the possible outcome of violence. So HCR stands for Historic, Clinical and Risk Management. And there are 10 risk factors that are historical that we look for, and then 10 clinical and risk management factors combined. The historical factors are what we call static. In other words, they're things from someone's past that are not really targets for intervention because they're not going to change much. But it's the dynamic risk factors that we really try and examine. Well, we try and examine them all, but really try and identify and then target in our treatment strategies. Now, I don't have a lot of time here to go over the historical risk factors that we look for, but these 10 have been empirically shown to be strongly associated with the risk of future violence. And what's important to note is that only a small number of these are clinical items. Most of them have to do with someone's adjustment to living, so their early and current environment, and also their personality style, the degree of antisociality, both in terms of their own personality, but also the people that they spend time with. The clinical and risk management items really look at particular factors to do with someone's clinical status, and also how we predict things, what their circumstances are going to be in the near future. And these are the risk factors, for example, problems with insight into their mental disorder or insight into their risk of violence. These are things that we try and identify to then target in our management plans. And what this graph shows is that in terms of the risk of violent offending, if that red line up the top is a kind of threshold that someone has to exceed in terms of their risk factors that will trip them over into a high risk of violence. If someone's static risk factors are low, then there's a much larger margin that can be accommodated in terms of the dynamic risk factors. And conversely, if someone's static risk factors are high, if they have a large number of those risk factors that are static, then it will only take a small number of those dynamic risk factors to precipitate violence. Okay, in the interest of time, I will move on to discussion about the DASA. Now, this is a risk assessment tool that is in fact really good in a range of clinical settings, not just forensic contexts. And it's really provides some structure for predicting the risk that someone might become violent within 24 hours. and it's used in civil and as well as forensic settings. And it's something that can be done, and we used to use it in the forensic context. Really each morning, we would, with the clinical team, run through this tool and score it. And it helped us to identify particular people who we thought might be at heightened risk of being or acting violently within the next 24 hours. And that then helped us to target our interventions to those particular people in that context. That's just briefly about how it's scored. But if anyone wants to know more about the DASA or any of these tools, I'm happy to have more discussions about it. An amnestic assessment is really looking at the pattern of someone's violence over a lifetime and trying to understand what the common factors are, with the notion that if someone has acted in certain patterns of violence in the past, that that's the way that they are more likely to do it in the future. And it's really based on information that we can get from someone's historical documents, their criminal record, but also from events that happen in clinical context, so on the ward, in the unit, or even in the community. Okay, in the last 5 minutes, I just want to tell you briefly about management, because that's the second half. The point of assessing and trying to identify someone's risk is then having some kind of structure for managing that. And in our forensic context, we used the CRAM framework, which is the New South Wales Health Clinical Risk Assessment and Management Framework, which has been authored for this particular purpose. We use a structure called TPRIM, which identifies 5 key areas that we need to use as a kind of base for devising a management plan. And you can see what that means there. And so every time we did a case review in the forensic unit, we did a TPRIM management plan. And whilst I'm not going to really talk in any great depth about particular treatments, they're really biopsychosocial in their structure. It might be about medication modification or psychological work, CBT for psychosis, or work on someone's insight, or changes, adaptations to their social circumstances. But the other parts of that assessment, I think, are really important. Thinking about the context in which you can manage someone, and is it safe to do so? Do they need to move to another part of the ward or another ward? Do they need to move away from particular people? Do we need to separate certain people? Restrictions are about whether someone can have access to leave. Is it safe for for them to have access to their mobile phone? Are there legal sanctions about contacting particular people that we need to enforce? And then implementation and monitoring is really about identifying who in your team is going to be responsible for implementing and monitoring the plan that you have devised. Now, we use this in the forensic context, both in the kind of medium to long term when we're doing our HCRs, but it's also a structure that I think is really useful in inpatient units, which are non-forensic, and you can use the same structure. What you put in that structure will depend on what your team thinks is important, but I think it's a very useful structure to use, and is a nice follow-on from the structured risk assessment tools that I talked about. Okay, I really just want to say that the laws, we do have laws in this country that help to provide, which give us extraordinary powers, really, to contain risk. And there are more bits of legislation, but the two that we commonly use are the Mental Health Act and then the Mental Health and Cognitive Impairment Forensic Provisions Act. But also just to mention that, just because someone has a mental illness and they may even be in a treatment setting, doesn't necessarily abdicate them of responsibility for acts of violence. And so it is important to remember that also they might be subject to the Crimes Act if they've committed an act of aggression in those contexts. It's a vexed topic, and I know that's often hard to pursue, but it is important to bear that in mind, that there are limits on someone's abdication of culpability. There are limits on that, and just because someone has a mental illness, it doesn't necessarily abdicate responsibility for their actions. Just to end on a good note, so I've worked with violent offenders. So these are people who have committed very serious offences. In most cases, they've been responsible for killing someone and have, in 95% of cases, serious psychotic disorders, schizophrenia, schizoaffective disorders. Now, these are people who are objects of great fear and fascination in the community, highly stigmatised, highly feared, and often highly publicised in the media. And it's not uncommon to see stories like this in tabloid journals, which don't do anything to help these people's future recovery. So in this context, we've really got to balance very clearly the treatment needs and recovery needs of our service users with the need to keep the community and victims safe, and also to give them a sense that justice is being served. So we use a model called the Good Lives model in our rehabilitation. These are forensic rehabilitation services, and they're really a strengths-based model, which comes from a human rights perspective that says that although it is important for offenders they have an obligation to respect other people's entitlements to well-being and freedom, they're also entitled to the same considerations. And trying to keep people safe and keep the community safe is actually very closely linked to these people's recovery. And that if we can weave them into the social fabric and try and improve their indices of social inclusion, that is actually the best way to try and reduce their risk of reoffending and to improve the safety of the community. So these are the treatment needs, what we call the criminogenic treatment needs, which through the work of Bonter and Andrews have been shown to be clinical and demographic factors that are most associated with the risk of violent offending. And what's important to note there is that on this list, it doesn't actually mention mental illness. And that's not to say that it isn't an important factor to target in someone's treatment, but it's not in the top 10. It's more about someone's capacity or their history, and really the future possibility of engaging people in pro-social community activities and linking them to pro-social community supports. So my last slide is really, and just to show a photo of two people who I've been involved in their care for over 10 years now. They've given explicit permission for me to show you this photo. They have undergone forensic rehabilitation, and they have both come from very, very disadvantaged backgrounds and very extensive histories of offending and very poor treatment engagement for their mental illness. But now I'm pleased to say they both live in the community. They share a flat together, which they take great pride in. And you can see the fellow on the right, that's his car, his border car, got his Ps, is now driving. They've both been engaged in voluntary work and are now considering engaging in paid employment for the first time in their adult lives. They have friends in the community and they've been woven into the social fabric. Since the day they entered the criminal justice system for their index offence and they've been engaged in treatment, there's been no history of violence for either of them. So I think that's a great success story for them and a great positive note to end on. I apologise for the quickness with which I went through all of those slides, but I think Julia wants to lead on to some questions. But
I'll just thank you first of all, Nick, for a really fantastic talk. It was really great to get all the background and also to finish on a note of demonstration of showing recovery is possible for people with a history of violence, and I know that that's something that's very important to you, and that's really great message to finish on. So thank you, Nick. I'm going to ask everybody to start populating your questions in the Q&A. We're going to stop screen sharing in a minute, but just while you're writing your questions, I'd just like to make you all aware of next month's webinar, which will be given by Prof. Dan Siskind. Dan gave our talk on clozapine last year, and many people wrote to ask, could we have an additional talk on clozapine adverse drug reactions? So that's what Dan will speak to next month. If you have any questions about referring patients to the TRSP, that's the contact for us. And these are other contacts where you can find more information about Mindgardens and TRSP. Thanks very much. So Nick, back to you. We've got a few minutes for questions, and we already have a few questions in.
Okay.
I'll just take them from the top. So the first is from Tove. And Tove's asking, Nick, can you comment on specific tools to assess risk of violence in the child and adolescent group? And that might be something that you could perhaps ask Tove to email you separately about.
Yeah, that's the HCR and other tools have been modified for use in specific populations. So I will, if it's Tova who I know, anyway.
It's Tove Rapagan.
Yeah, okay. So if you just email me, I will certainly dig those out for you.
Fabulous. Another Nicholas has said, great talk. And Nicholas is wondering, are there data that indicate certain cultural upbringing or cultural beliefs or norms lead to greater incidents of violence? And if so, what do those data show?
That's a great question, actually. And Nicholas, I'd be making it up, so I don't know the answer to that, but I will speak to my colleague who is the Professor of Forensic Psychiatry at New South Wales Uni. I'm going to pose that to her because I think that's really a good question. We do know that the immigration experience acts as enhances, I guess, can be an early life adverse experience that kind of enhances vulnerability generally to the development of mental illness. But I am going to find out the answer to that question for you if there is any data.
Thank you for that, Nick. We've got a couple of questions about the assessment tools. So Natasha has said, great presentation, Nick. Would you recommend use of a community modified DASA tool for all CMHDA assessments, and at what frequency?
Yeah, as far as I know, it's not used in the community, and I think it was really devised for inpatient settings. I'm always cautious about recommending the use of tools unless there's adequate training and people do it in a reliable fashion. But having said that, I think it could be modifiable for the community context, and perhaps if it's not done on a daily basis, it might be done in circumstances where people feel there is a risk has arisen, and then it might be done for a period of time in that context. But I might actually find out if it is being used at all in community contexts, because as far as I know, it's not.
Okay, that's great. Thanks, Nick. And Bev Moss has asked, are you able to distribute the HCR20 and DASA?
Well, I can certainly do that for reference. What
They're not subject to copyright, Nick?
I don't know. I'll find out about the HCR. Both of them are promoted by New South Wales Health.
Yes, but require training, yes?
Exactly. That's my main caution about it is both of them require training, and especially the HCR. And so unless it's done reliably, it may be of no value, and it may be of less than no value, actually. So whilst I'm happy to provide a copy, what I would say is important to get into contact with the people in your LHD or your service who would be regular users of those tools, if you're thinking about implementing them in your teams, to seek their assistance. And there's another body, which is a statewide service called the Community Forensic Mental Health Service. And I can certainly provide contact details for them. They are really good at training in use of HCR, DASA, and the CRAM framework. So before you think about implementing these tools, please make sure that you seek out adequate training.
Right. Now, Nick, we've got a bit of a curly question from Kim. So you spoke about this issue of the Crimes Act and how, you know, certain acts of violence, people should you know, shouldn't always be permitted and excused by their mental illness. So Kim is asking, when a police complaint is made against an inpatient who's violent, typically nothing ever comes out of such a complaint, and the matter's typically dismissed in court. And that may result in the victims rarely reporting such violent acts, as it results in no action. What could be done about this? Big question.
Look, it's Kim, I've heard this time and again, and I know I've been in those contexts where there's been a discussion, certainly in an inpatient context, about notifying police to have someone charged. And there's often a sense of fatalism amongst the clinical teams that nothing becomes of it. Even if it does get to court, then it'll be thrown out by the magistrate or the judge because someone was in a treatment setting. And it's even more complex if someone is being treated involuntarily under the Mental Health Act. All I can say is that in a kind of reactive sense, if you're in a context where this situation arises, really important that people feel, who are working on the ground, that this can be raised and discussed with their campus nurse manager and the psychiatrist who's on call, or the clinical director for that particular unit. I think discussion needs to go on at that level, but it shouldn't just be dismissed with the belief that nothing will become of it. I think in a more proactive sense, I think it's something that really should be discussed by clinical services, especially acute inpatient services. It should be discussed proactively about how to manage this scenario and what the steps might be. So there's some kind of proactive thinking about it. Kim, I don't want you to become fatalistic about it. You know, if you see it, I think it's very important to have those discussions. I guess that's my main message to you.
Thanks, Nick. And look, we've reached 1 o'clock, and we'll have to finish up there. There are a few more questions that we haven't got to. What we've pledged to do is get responses from Nick on those questions and provide all the resources that Nick has indicated he can make available. We will put those all together in the email from TRSP about the upcoming webinar to everybody who is registered with their email for this webinar, and it will become available to you within about 2 weeks. So for now, I'll just thank Nick again for a fantastic talk, and thank you for attending today, and look forward to seeing you at future webinars. Bye.
Thanks, everyone. Thanks, Julia.